The neurologic exam has a lot of components to it, which includes the mental status exam and musculoskeletal exam. For purposes of this video, we are going to concentrate on the cranial nerves and some peripheral nerves, including the deep tendon reflexes. During the cranial nerve examination, it's very important to explain in detail what you want your patient to do. Starting out with cranial nerve 1, the olfactory nerve, it tests the function for smell. So what you want to do is ask your patient to close their eyes and to cover one nostril, and then you're going to have them smell a particular substance. So if you'll close your eyes, cover one nostril, and smell.
Coffee?
Excellent. Cover the other nostril, and smell.
Vanilla?
Great. Cranial nerve 2 is the optic nerve. And there are several pieces to test for the optic nerve. You're going to test visual acuity. So with one eye covered, have the patient with their arm extended holding the card and to read starting at the top to the very bottom to where they cannot read anymore.
958742843 8745 63925 428365 8374258 937826. I can't read.
Okay, this is where she got all of them correct, and that is where you mark the vision as 20/25. You do that with both eyes. Testing visual fields, stand closely to your patient, have them stare at you, and then have them identify which fingers you are moving. Use yourself as the control.
That one? That one? That one? That one? That one? That one?
Excellent. Cranial nerve 2 and cranial nerve 3 control the function of pupillary constriction, direct and consensual. So what you want to do is turn the lights out and then shine the light in one eye and look to see that that pupil is actually constricting. Then you're going to remove the light, and as you re-shine it in that eye, you're going to look at the other eye to see if it is constricting. So this would be direct constriction, and then looking at the opposite eye, consensual constriction. And then you need to do it on the opposite side. Direct, consensual. Extraocular movements are controlled by cranial nerves 3, oculomotor, 4, trochlear, and 6, abducens. To test this, have the patient keep their head still and just with their eyes follow your finger and make the shape of an H. You're looking to make sure that there's full range of motion of each of the eye muscles. To check for accommodation, ask the patient to follow your finger inward, and as their eyes cross, their pupils will constrict. Cranial nerve 5, the trigeminal nerve, has two different components. It has a motor component and a sensory component. The motor component innervates the masseter muscle, so ask your patient to clench down, and you can feel the muscle tighten, and you can see it. And then the sensory component, there's three branches, V1, V2, and V3. So you want to test sharp and dull sensation in each of these areas. First, demonstrate to your patient what sharp is going to feel like and what dull will feel like. Now close your eyes and then tell me if you feel sharp or dull.
Dull, sharp, sharp, dull, dull, sharp.
Cranial nerve 7, the facial nerve, has two components as well. The motor function, you can either ask your patient to close their eyes very tightly or to raise their eyebrows to test the upper portion. Close your eyes very tightly and don't let me open them, okay? And raise your eyebrows. Either one of those will test the upper portion. Now, I want you to smile and show teeth. You want to make sure that it's symmetric, or you can ask them to blow out and make a bubble with their cheeks. And don't let me push them in. That tests cranial nerve 7. Cranial nerve 7 innervates the anterior portion of the tongue and distinguishes the difference between salty and sweet tastes. The posterior portion of the tongue, innervated by cranial nerve 9, distinguishes the difference between bitter and sour. Ask your patient to stick out their tongue and apply a Q-tip on the very tip and see if they can distinguish what the taste is. Open your mouth, and without putting your tongue back in your mouth, can you tell me what that is?
Sweet.
Very good. Now open your mouth again, a bit more widely so that we can get to the back. And can you tell me what that is?
Bitter.
Very good. Then you want to be nice and give your patient something to drink to get the taste out of their mouth. However, we have nothing. Cranial nerve 8, the acoustic nerve, tests hearing. You can do this by asking the patient to do a whisper test or rubbing your fingers by their ears to see if they hear it. So with your eyes closed, I'd like you to tell me on which ear do you hear me rubbing my fingers?
That one. That one.
The Rene test, you're going to tap the tuning fork and place the base of the tuning fork in the back of the ear. Bone conduction should be shorter than air conduction. So when the patient doesn't hear it anymore, bring the tuning fork towards their ear and see how long it takes for them to not hear it through air conduction. Air conduction should be twice as long as bone conduction.
Okay.
Cranial nerve 9, the glossopharyngeal nerve, and cranial nerve 10, the vagus, innervate the palate posteriorly. So as you have the patient open their mouth and say ah, look in the back of the throat to make sure you see symmetric rise of the palate. Ah. The motor function of cranial nerve 10 innervates the vocal cords. So as you're talking with your patient, make sure that you are noting if there's any hoarseness in their voice or not. Can you say, my favorite teacher is Dr. Hogan?
My favorite teacher is Dr. Hogan.
Great. Cranial nerve 11, the spinal accessory muscle, innervates both the sternocleidomastoid muscle and the trapezius. Ask the patient to shrug their shoulders against resistance, one way, and then also to turn their head towards their shoulder to test the other. The hypoglossal nerve, cranial nerve 12, innervates the tongue motor function. Ask the patient to stick their tongue out, make sure that it's midline, and then move to the left and move to the right. And that completes the cranial nerve exam. Testing proprioception and cerebellar function, you're going to ask the patient to do some rapid finger to nose movements. So with them keeping their head still, and touch your finger to your nose, and then touch my finger. Touch your finger, touch your nose, touch my finger, touch your nose. What you want to make sure is that the patient comes directly to the fingertip and doesn't go beyond. Now you want to make sure that the patient can do it with the other finger. Touch your nose, touch my finger. Touch your nose, touch my finger. Touch your nose, touch my finger. And you want to make sure that you cross over the midline. Rapid hand movements is where you ask the patient to flip their hands over and back down as quickly as they can. To test for balance, you do the Romberg test. Ask the patient to stand with their feet close together and their arms to their side. You're going to tell them that you're going to ask them to close their eyes, and you're going to tap them gently on the back to see if they can maintain their balance. And be ready to catch them in the event that they don't. So if you'll close your eyes. If they maintain balance, you can open your eyes. Ask them to separate their feet a little bit. And nudge them a little bit harder this time to see if they're able to maintain their balance. Again, being prepared to catch them should they fall. Watch the patient's gait by asking them to walk across the room in a straight line. And turn around and walk back. Testing the spinothalamic tract, you want to make sure that the patient can distinguish between sharp and dull on the upper and lower extremities. Again, demonstrate to them what sharp and dull is while their eyes are open. Sharp and dull. Now ask them to close their eyes and tell me if it's sharp or dull.
Sharp, dull, sharp, sharp, dull, sharp, dull, sharp, dull, sharp, sharp, dull, sharp, sharp.
Testing the posterior columns, you're going to see if the patient can distinguish vibratory sensations. Using a 128 Hertz tuning fork, you're going to tap it and you're going to place it on a bony prominence on their foot. So you're going to ask the patient to close their eyes and see if they can feel this.
Yes. 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 Yes.
Okay. Testing proprioception, you're going to demonstrate to the patient what you're going to ask them to do with their eyes closed. So initially, you want to grab the patient's large toe, you want to grab the patient's big toe on the sides and demonstrate that this is up and this is down. Now, with your eyes closed, I want you to tell me if I'm moving up or down. You want to make sure that you move the other toes out of the way so that they can't feel you moving one way or the other along the lateral aspect of the other toes.
Up, up, down, down, up.
And you can see that I'm just testing very small, slight movements. Again, you need to test on the other side as well. Close your eyes.
Down, down, up, up, down, down.
Cortical sensory function is tested through stereognosis and graphesthesia. Stereognosis is giving a patient an object in their hand with their eyes closed to see if they can identify it. If you'll please close your eyes and tell me what this object is.
This is a paper clip.
Very good. And then again, what you do in one hand, you need to do in the other.
This is a quarter.
Excellent. You may open your eyes. Anesthesia is tested by asking the patient to give you the palm of their hand, closing their eyes. You're going to draw something on their hand and they need to identify it. Make sure that you're drawing it in orientation to the patient and not outward.
8. B.
The last step to complete this neurologic exam is doing deep tendon reflexes. Starting out with the triceps reflex, you want to ask your patient to relax as best they can, and if they don't relax easily, you can have them make a fist with the opposite hand. Well,
Okay.
Not that much.
oh, there we go. Did you just do that? Biceps reflex. If you have a larger patient that you're unable to feel the tendon, you can ask them to make a fist and flex so that you're able to get your thumb over the tendon. And then, once you've located it, have the patient relax their hand. Flex, perfect, and then relax your hand. For the brachioradialis, not so easy. Then the patellar reflex. And you want to get right into the groove just below the patella. If you're having a hard time eliciting the reflexes, you can ask the patient to pull against their hands so as to concentrate their energy in the upper extremity so that you can get it, so that you can elicit the reflexes better on the lower extremities. The Achilles reflex can be elicited by supporting the foot so that it is parallel to the floor and tapping the Achilles tendon with the reflex hammer. The final reflex is the Babinski. You're going to move along the lateral aspect of the foot, moving in towards the great toe. An intact upper motor tract, you're going to have the big toe move downward. A positive Babinski, you have an upward going toe and flaring.